Okay, so we're going to talk about Staphylococcus and Streptococcus. It's two different genuses. So we'll talk about how we recognize them on the plates, the biochemical tests that we do to identify them, what kind of infections they cause, certain virulence factors that they might have to lead to infections that help them evade our immune system. Take a look at these objectives when you're studying. What's the general characteristic of Staphylococcus genus as a whole? What are their main characteristics? Compare Staphylococcus to other gram-positive cocci. So we're going to do that today with Staph and Streptococcus. Those are the two main genuses of gram-positive cocci. There are other gram-positive cocci that can cause disease, but we're not going to talk about them. So just keep that in mind if you're sitting on a microbiology bench and none of your biochemicals are fitting Staph or Strep. There are other things out there. Compare the clinical infections associated with different Staphylococcus species. We'll talk about Staph aureus and the kinds of infections that it causes, and then we'll talk about two other kinds of Staphylococcus organisms, and they cause unique kind of infections. They have their own sort of niche in causing infections in humans. Develop an algorithm of key tests, and we'll work with what I've developed for our laboratory. When you go to a different microbiology lab, they'll have developed a certain algorithm to fit the biochemical tests that they use. But if you understand the algorithm or how we get to our identity, it can really make memorizing all these senseless facts. They seem senseless at first. It kind of makes them come together, and we'll talk about it when we get to that point. State the purpose and the principle for each test that we use to identify Staph. We're not going to talk about as many as we did with gram-negative bacilli. There's a few, but make sure you know how they work, what we use them for. Discuss the characteristics that should be utilized to identify Staphylococcus-like organisms from a clinical sample. So what do we use when we have an organism like this? How do we get to these algorithms? What characteristics do they have? And then why is methicillin vancomycin resistance a serious clinical problem? And what's the principle and the purpose for the D-test? So I'm going to try to revisit stuff that you guys had last week. We didn't get to talk about it together. And so we're going to stress that a little bit more in our lecture today, and then we'll revisit it a little bit in lab today to make sure that stuff sticks. And it's kind of old technology. Most places don't use the disc diffusion method anymore, but it's a good way to understand how antibiotics work. So the general characteristics for Staphylococcus genus. The microscopic morphology, you have gram-positive cocci. They're catalase positive. That's a biochemical test that we'll do. They can be in singles and pairs and in clusters. I've got clusters highlighted and underlined. These are important stuff. They're bolded and underlined. Okay, so if you hear gram-positive cocci in clusters, you want to think automatically Staphylococcus. All right, and we'll talk about strep, which is a gram-positive cocci in chains, usually. So you'll think strep when you see chains. And so a lot of times they'll describe this as a bunch of grapes. It looks like a bunch of grapes just kind of clustered together. The colony morphology or the macroscopic morphology, they're usually white, creamy, maybe a light gold. They might be described as buttery looking or butyrous. Some species do produce beta hemolysis, so your Staphylococcus aureus is notorious for being beta hemolytic, but not always, but most of the time. General characteristics for Staph species, they're non-motile. They don't produce those spores when they're faced with harsh conditions. They don't have capsules. They're usually facultative anaerobes, so they'll grow well both anaerobically and aerobically. So you'll see them on both types of cultures, aerobic and anaerobic. And Staphylococcus is just an example of one of those. Okay, so the first organism that we're going to talk about it's grouped in with the Staphylococcus genus, but it's really kind of an outsider. It's Micrococcus luteus. And if you turn the lights off, he's kind of an oddball. He has a distinct yellow pigmented colony. I'm going to try to get one for us to see in the lab. But if you look kind of hard, it's intense, bright yellow colonies. The microscopic morphology, just like staph, it's a gram-positive cocci. Everything we're talking about today is gram-positive cocci. The test that we use to identify this organism is the catalase test, and then you might do the coagulase test. So the catalase will be positive, and the coagulase, if you do it, will be negative. Usually when I see this bright yellow colony morphology, I do my catalase and I do the test that we use to diagnose this, or to identify or confirm this organism, and that's the modified oxidase test. I don't even waste my time with the coagulase test because it doesn't fit my algorithm. It's generally a non-pathogen, but if it's given the opportunity to be a pathogen, it's going to take that opportunity. But usually it's usual flora. This is a chart from your book, and it breaks down the difference between Staphylococcus genus and the genus of Micrococcus. And what I want you to really take from this table here, there's a lot of different ways to tell the difference between the two. So your facility that you happen to work at, or where you go do your clinicals, might use a different test than what we use in our laboratory. For test purposes, for BOC and for our lab, our tests, I want you to know the modified oxidase reaction. So Micrococcus is modified oxidase positive, and Staphylococcus is negative. Basically, I remember what's positive, and I don't worry about memorizing what's negative. So if you see modified oxidase positive, see the M's, put the M's together, Micrococcus, you know to identify your organism as Micrococcus. And that's all we're going to talk about for Micrococcus. He's not a super important organism. There's not a lot to him. He's just not usually a non-pathogen. So think of lemon yellow, modified oxidase positive, catalase positive. What's the clinical significance of Staphylococcus? So why is it important clinically? Staphylococcus aureus is the first organism we're going to talk about, and it can usually reside in the nose of humans. 20 to 30% of people can have Staphylococcus in their nose and not exhibit symptoms, so they're carriers. And that number is probably higher now. It can be recovered from almost any clinical specimen, either as a pathogen or as normal flora. So it's everywhere on our bodies, and it could be in any kind of, it can cause basically any kind of infection. It usually produces like skin and soft tissue infections, but it can also lead to systemic infection. So it might start as a localized infection like a bed sore, but then penetrate deeper tissues, get into the bloodstream, travel to whatever organ. Once they get in the bloodstream, they have access to any organ. They can cross the blood-brain barrier and get into the central nervous system. It can really do anything. So skin, bacterial sepsis. Let's see. The virulence factors for Staph aureus. This is what it has, characteristics that it has that helps it cause disease in humans. So there's enterotoxins. We talked about exotoxins, and we talked about endotoxins. Remember what the difference was? How's an exotoxin different from an endotoxin? What is an endotoxin? Do you remember? Anybody remember? Not in the bloodstream. Exotoxin. It's a component of usually gram-negative organisms. Remember, their outer cell wall has LPS in it, which is an endotoxin. It's component inside the organism. So it's like a toxin that's made up of the cell. Or inside. Think of inside. Okay? Whereas an exotoxin is secreted outside. All right, so we talked about gram-negative organisms. They have that outer cell wall, and it has an LPS component in that outer cell wall. So if you are on heavy-duty antibiotics, it's breaking up that gram-negative organism, and all those LPS tidbits are floating around in your bloodstream. And your immune system reacts to that. It's a toxin. And your immune system reacts to that, and it could cause shock and death and organ failure. So endotoxin is something that's made up of inside the cell. Exotoxin is outside. An enterotoxin is an exotoxin that affects your gastrointestinal tract. So if you see entero, it can kind of mislead you because it has an N, and you want to think inside. But entero typically means your GI tract. We'll talk about enterics, which has that same prefix. So it's an exotoxin that the organism secretes, and it can cause diarrhea and vomiting. It disrupts the GI tract. There's other types of toxins that can cause food poisoning, and these are heat-stable toxins. So just because you heat your food up, it might kill the organism, but if it already secreted the toxin, it's not going to help you do anything. You're still going to get food poisoning. And an example of that, and you don't need to memorize this, is TSST1, or toxic shock syndrome toxin, that causes that organism. It also produces an exfoliative toxin, which causes the scalded skin syndrome, and it makes the top layer of the skin kind of slough off. Let's see, it produces hemolysins, which are cytotoxins that the organism secretes that destroy red cells, right? And we can see that on our sheep blood agar. We talk about alpha, beta, gamma hemolysis. There's also, I think that's a delta. Basically, I just want you to know about the three that we talk about, the alpha, beta, and gamma. So the beta lysin lyses the red cells completely, and we can see that on sheep blood agar. Enzymes that it secretes, the coagulase enzyme. We'll talk about the coagulase test and how to detect that enzyme. They don't really understand how it works, but it helps us to identify the organism. Hyaluronidase, it breaks down hyaluronic acid, which is in your connective tissues, so that it can spread. Let's see, lipase breaks down fat in your tissues, so again, it can spread. So these are things that can, help take advantage of the environment that it's in your body to cause infections. Protein A, I can tell you that this is on the exam. This is something that's secreted that helps the organism avoid phagocytosis. So basically, this is my sad little illustration of an IgG molecule. And if you remember, IgG has two regions, right? It has the Fab region and the FC region. And one region binds to the antigen that is supposed to be removed from the circulatory system, right? It's the foreign particle that binds to that region. And the FC region binds to the white cell and allows the white cell to recognize the other antigen as foreign, and it phagocytizes it. Well, the protein A antigen on the Staph aureus organism binds that FC region. And so it can't bind to the white cell, so it can't be phagocytized. So it avoids it in that respect. The epidemiology of Staph aureus, the primary reservoir is usually in the nares, but we can find it in all other kinds of skin surfaces and other sites of the body. It can be responsible for outbreaks in hospitals like your nurseries, your burn units, your surgical patients, especially if a surgeon has it in their nares and they're not washing their hands well. So they can spread it to their patients. Transmission is usually through hand washing and fomites, so it's not an airborne infection. It's something that you pick up in your environment. Some infections that Staph aureus can cause, it's generally referred to as pus-forming kind of infections. So you got your furuncle, which is a boil, a painful inflammation of the skin with pus. A carbuncle is basically a furuncle on steroids. So if you think, I associated car is very large, right? So it's larger than a furuncle. So it's when it gets larger and it penetrates deeper tissues. Folliculitis is when it gets into the hair follicle. Bullous and impetigo is when you see this small zone of redness around the pustule. What else? Extensive exfoliative dermatitis. So this is that skin infection that we had talked about with that toxin, and we can see it in renal failure patients most often, but we can also see it in immunocompromised patients, and basically it looks like all the skin's coming off in their bodies. Infections can be from mild to very severe. These can last a couple of days. Usually children recover, whereas adults usually tend to pass away. Toxic shock syndrome is associated with superabsorbent tampons. Your clinical presentation, we've got a high fever, you might have a rash, watery diarrhea, vomiting, dehydration, a drop in blood pressure, and then we have some abnormal coagulation going on. So your coagulation factors are all used up because you're clotting uncontrollably, and then you're out of coagulation factors, so you're bleeding uncontrollably. That's DIC. Abnormal BUN and creatinine because your kidneys aren't doing well, and sort of system or multi-system failure. Food poisoning from the enterotoxin. Usually we can see a presentation like 2 to 8 hours after ingesting the toxin. You have abdominal pain, diarrhea, vomiting, nausea, those kind of things. And it usually resolves on itself. On its own in 1 to 2 days. Other kinds of infections that can cause pneumonia in people after they've had influenza. It can get in the bloodstream and travel to the heart. We see this a lot in people that shoot up drugs. Osteomyelitis, so it can get in a bone. Arthritis, if it gets in the joint. So basically, Staph aureus is the big dog. If you don't learn anything, if you don't remember anybody in this whole course, remember Staph aureus. We won't talk a whole lot in depth about other organisms so much as we did with Staph aureus. Let's see, I'm going backwards. Staphylococcus epidermidis. This is like the good twin of Staphylococcus aureus. It's common skin flora usually. It's not clinically significant unless we see it from a site that's usually sterile. That's when we would question think that it's involved in an infectious process. If it's a pure culture and there's a lot of this Staphylococcus epidermidis growing, then it would cause a red flag. So when it does cause disease, it causes nosocomial infections. And nosocomial infections is hospital-acquired infections. So it's usually because of some kind of a medical procedure that a patient undergoes, like maybe a urinary catheter for a surgical procedure. Maybe they had a cardiac catheter put in. Maybe they had heart valves or a shunt put in to empty out spinal fluid. A very common cause of hospital-acquired urinary tract infections. Even just a brief catheter that doesn't stay in very long can cause a urinary tract infection if it's not an aseptic technique isn't used to put it in. Basically, know that this guy loves plastic devices. So if you have some kind of a question, test question, or case scenario, and it's talking about some kind of a catheter or some kind of implant that's plastic, you want to think of this guy. And let's see, Staphylococcus saprophyticus. This one usually causes urinary tract infections in young sexually active women. So I always think of the corpse bride, because a lot of times women will come back from their honeymoon and they'll come back with a urinary tract infection because of this one. It's usually present on skin or mucous membranes. It's like an opportunistic pathogen, so it just kind of can take advantage of circumstances if they are good for it. Usually it's present in very low numbers, so less than 10,000, which is 10 colonies on our plate, right? If we think about our plate and how we quantify growth, when we quantify a urine culture, we count each colony individually, right? So 10 individual colonies. 4, 5, 6, 7, 8, 9, 10. Does that coincide with an infection, those quantities? Usually, if it's less than 15K CFU, or 15 colonies, it's not an infection. It's usually usual flora. It's just contamination. All right? Anything present in greater than 15 colonies can be considered probably a pathogen at that point. So if it's present less than 10,000 or 10 colonies, it's just usual flora. So it's normal to be in there. But in this case, with this organism, with females, sexually active females, if it's a pure culture, it's still considered significant. And some people will even identify it if there's other things growing there. So remember, sexually active females, urinary tract infections, and Staphylococcus saprophyticus. It's significant in very low numbers in sexually active women. Otherwise, we don't identify it. We don't mess with it. Okay, so specimen collection and handling. We're not going to go into a whole lot of depth about this because we talked about it in a previous lecture. But basically, it depends on the site of collection. So if you're collecting, if they suspect a urinary tract infection, you're going to collect a urine, and you use those protocols for urine collection. Clean catch midstream. If you suspect pneumonia, then you're going to collect a sputum, and basically you just want to transport it to the lab without delay. Use some kind of a transport media if it's necessary. Transport media prevents drying. It maintains the environment. It keeps the organisms in their representative numbers. It keeps them from multiplying. Used for Staphylococcus organisms, there's not special handling that's involved. We'll talk about some other organisms where you'll have to treat them special, but not for this category. So microscopic examination, we're going to see a large number of gram-positive cocci if it's an infection caused by a Staphylococcus organism. Then when we do our gram stain, we're going to see a lot of gram-positive cocci usually. We're going to see a good amount of white cells, PMNs. We might see proteinaceous debris. Ideally, for these kinds of joint fluids or any kind of fluid, an aspirate is best. Even if it's a wound, an aspirate is best. But usually they'll send a swab. Ideally, you want them to send two, one for the gram stain, one for the media. So how do you isolate Staphylococcus from the clinical sample that you collect? It grows very well on your routine auger, your sheep blood, your chocolate. your thioglocolate broth. Why wouldn't it grow on McConkey agar? Right, it's not gram-negative. McConkey agar only grows gram-negative bacilli. Very good. So if it's very heavily contaminated specimen, if it has a lot of normal flora in it, you can use selective agar, right, to help you out. So there's different types of selective agar here, and they might be on your media worksheet, so it'd be a good time to fill that out. Mannitol salt agar is selective and differential. It has very high salt content, so that high salt content allows it to select for Staphylococcus species. It differentiates between Staph and Staph aureus based on its ability to ferment mannitol. So Staph aureus can ferment mannitol, so it will be a yellow colony. Other kinds of staph will not ferment mannitol, and so they'll grow a red colony. Okay. CNA agar is selective. You could also say differential because it is a sheet blood. Both of these agars are sheet blood, so you might see some homolysis on there, but it's not reliable, not like the sheet blood agar. So CNA and PEA select for these gram-positive cocci, so it'll inhibit your gram-negative rods if they're contaminating your specimen. Chroma agar for Staph aureus, it's selective and differential. This is neat because I'm not going to talk about the ingredients in there, but it selects for the growth of Staph aureus. So if there's colonies on there, you can presumptively say that it's Staph aureus. But it also differentiates between Staph and other Staph aureus. And Staph aureus based on, it differentiates between Staph aureus species that are methicillin resistant and methicillin sensitive. And it does that with a color reaction. So if it's resistant to methicillin, they'll be pink, and if they're not resistant, they'll be clear. So they might use this to screen hospital inpatients for MRSA. They'll swab their nares and put it on here, and all you got to do is look for pink colonies, and you know that the person has MRSA. So there's a lot of selective agar out there to help make our lives a little bit easier. So we got to keep in mind what their purpose is and how to use them. Here's a picture of Staph aureus. We see it's pretty medium-sized colony, pretty good size. It's white, it's opaque. What else? Might be, yeah, it's pretty shiny. What's it doing to the red cells? What kind of hemolysis? Beta hemolysis. It's white, right? We can see right through. It's not green. So that's a typical colony of Staphylococcus aureus. Here's coag-negative staph, or your Staph epidermidis, or Staph saprophygitis. Anything usually other than Staph aureus is white, opaque. It's not hemolytic. So it's usually just, we just group it as coag-negative staph. Okay, so we're going to talk about the different tests that we use to identify these organisms we just talked about. Okay, remember we talked about Micrococcus first, the lemon yellow colony, and this is the test that we use to identify it. This is the confirmatory test. Okay, it's the modified oxidase, or the brand name you might see is microdase disc. That's what we'll use in the lab. So its purpose is to identify Micrococcus. And the procedure is you just smear some of the colonies on the disc and wait for a blue color to develop in 30 to 60 seconds. And if it's blue, you can call it Micrococcus. You can also touch a colony with a Q-tip and apply the modified oxidase reagent and look for a blue color. Okay, so blue is positive for Micrococcus species. You can't really say Micrococcus luteus, but when we have Micrococcus in the lab, it'll be Micrococcus luteus. So I just stuck that in there. And then negative, if it's negative, it means it's some kind of a staph. Okay, there's no blue color. catalase is, the purpose is to detect the enzyme that the organism might produce. It's the catalase enzyme. And this is the initial test that's used to differentiate gram-positive cocci. Notice that's in bold, right? What's the very, very first test that we do when we're identifying organisms? It's the most common test performed in microbiology. It's not a biochemical test, really. It's a gram stain, right? That's the first thing you want to do when you're working up an organism. You don't know what it is. Find out what it is. Is it gram-positive cocci? Because you're going to treat a gram-positive cocci differently than you would gram-negative bacilli, right? All right, so say we saw gram-positive cocci. And let's say it's a lemon yellow color. It's very distinct. What test are we going to do? Actually, wait. I don't want to do that just yet. The catalase test is the very next test that we're going to do. If you've got a gram-positive cocci on your gram stain, the next test you do is the catalase test. And it's used to differentiate gram-positive cocci. Basically, it divides it into two genuses, your staph or your strep. Okay? So if it's negative, it's a Streptococcus genus. One of those. If it's positive, that means it's either a Staphylococcus or a Micrococcus. Because Micrococcus is catalase positive also. So at this point, well, is it a bright lemon yellow color? I mean, it's bright lemon yellow. What test would you do if it's bright lemon yellow colony? Modified oxidase, right? All right. If it's not lemon yellow, then don't worry about the modified oxidase. It's not fitting your algorithm, right? So lemon yellow color indicates a Micrococcus. If it's not lemon yellow, then we're going to go a different way. It's probably a Staphylococcus. Okay? And this is the flow chart that you've printed out for labs. So for a catalase, it's real easy. It's basically touching the colony to a drop of hydrogen peroxide. And if the organism produces the catalase enzyme, it's going to break down the hydrogen peroxide into water and oxygen. So we'll see a bunch of bubbles produced. So the principle here is hydrogen peroxide, or H2O2, in the presence of the catalase enzymes becomes water and oxygen. So once we touch, we'll use a wooden applicator stick. If you use a metal loop, you want to touch the metal loop to the hydrogen peroxide without any organism and see if it bubbles on its own. Because there's some kinds of metals that'll bubble on their own, so you'll get a false positive. So you always want to touch your loop and see if that happens. I like to use a wooden applicator stick, personally, because it's faster. I don't have to incinerate my loops. So you just touch the colony and then touch it to a drop of hydrogen peroxide that's in a dish or on a glass slide. And you want to look for a vigorous production of bubbles. It's going to be very obvious, very fast, violent production of bubbles. Okay, so if it's positive, that means you've got either a staph or a Micrococcus species. If it's negative, you've got a strep. So this is a good test question. How do you differentiate gram-positive cocci? Or what test is used to differentiate your gram-positive cocci? Catalase is the #1 test, or the first test that you do to differentiate. Do I got a staph or do I got a strep? Right? Okay, so the coagulase test. The coagulase test is the next test that you do if it's not lemon yellow. If it's catalase positive, you want to do a coagulase. And basically what this test is doing is you're checking for Staphylococcus aureus. Is it Staph aureus? Okay. Let's see. This is this is talking about the slide test. So there's two methods. There's a slide test and there's a tube test. All right? The slide test detects this clumping factor. So if the organism detects this clumping factor, then it's going to clot or clump plasma from human blood or human, rabbit, pig plasma. All right? So the principle is if the organism produces the free coagulase, which is the same thing as this clumping factor, then the bacterial cells will cause the plasma to clot. And the procedure is just to mix water or saline suspension of the organism with a small amount of plasma and check for clumping, which indicates positive. All right. All negative slide tests have to be confirmed with the tube test. So some of your Staph aureus isolates don't produce this clumping factor or this free coagulase. They only produce the coagulase that we test for in the tube test, which is like, they've changed it. It used to be your bound coagulase, and now I think it's like Staphylococci or something like that. So it's testing for two different types of the clotting factor. The tube test, you want to take 0.5 mils of the plasma and some isolated colonies, mix them in there with the plasma, and then incubate it 37 degrees and check it after 4 hours. If it's negative at 4 hours, you want to incubate it a full 24 hours. All right. If it's positive at 4 hours, go ahead and call it positive. So the interpretation is if you see a clot, if the plasma turns into a nice solid clot, it's coagulase positive Staphylococcus, which is Staph aureus. You've identified your organism at that point. It's Staph aureus. If there's no clot, then you have some kind of coagulase negative Staphylococcus. And those are the abbreviations that you might see, CNS or CONS. So it could be Staph epidermidis, it could be Staph saprophyticus, it could be a whole wide array of different coag-negative staph. We don't usually care. We only identify them, we'll identify Staph epidermidis if it's from if it looks like it's a pathogen. If it looks like, say it's a urinary tract, they think it's a urinary tract infection, and it's a pure culture, and there's a whole lot of growth on that plate. Or if it's from heart valve or surgical site infection or something like that. So we don't worry about it unless we have a reason to worry about it. Does that make sense? Otherwise, we just call it coag-negative staph. And then we talked about Staph saprophyticus. Remember, it causes urinary tract infections in females. So we would only identify it if it's from that certain patient population. Okay? And that'll make more sense when we get in the lab and we start doing it. So here's just a picture of the coagulase test, and we can see a nice good clot in there, and this one's negative. So this is Staph aureus, and this is some kind of coag-negative staph. All right? On a slide, you'll see, you'll see clumping. It kind of, there's different kinds. Usually people use like a latex test that has a color. It looks like they've attached it to a latex bead, so it's kind of like gray. And we'll talk about those, I think, at the end of the presentation. It has some pictures of some alternative methods. So the slide test is not used anymore. Now we use like a modified slide test that's more sensitive. Okay, so this is differentiating coag-negative staph. So this is if you've got a urine sample on a sexually active female and it's a coag-negative staph, then you have to test to see if it's Staph saprophyticus. Right? So what you could do is you can do the novobiocin susceptibility test. And basically what you do is you streak the organism on a sheep blood agar plate. And you want very heavy confluent growth. So you'll streak it down, and you'll streak it left, and you'll streak it right. You want a heavy lawn of growth, right? I like to use a swab because I feel like it does better than a loop. So once you've got this nice heavy inoculum on your plate, you put the novobiocin disc in the center of that plate. And so if the organism, this is an antibiotic, and basically you're looking to see if the organism is sensitive to the antibiotic or resistant to the antibiotic. If it's resistant, then you have presumptive presumptive staph saprophyticus. If it's susceptible, then you've got some other kind of coag-negative staph, like staph epi maybe. Okay, so link novobiasin disc with staph saprophyticus, and it's resistant. This is the latex agglutination slide test I was talking about for the coagulase. So they're modified, so they might be attached to some kind of a particle instead of not attached to any kind of particle. So it helps you see the agglutination better. This one tests for clumping factor and protein A, so you don't have to back it up with a tube test. There's other things like molecular methods that you can use to identify Staph aureus. You can actually test for methicillin resistance, but we're not going to go into those kinds of methods, but just be aware that there's other molecular methods out there. Here's a picture of the novobiasin susceptibility. So notice it's real heavy growth. It's a lawn of growth. And that's what you want to do when you're testing for antibiotic sensitivity, because you're looking for a zone of inhibition. And the zone of inhibition is this area of no growth here, right? So like last week, hopefully you measured the diameter of the zone of inhibition, and you got a diameter in millimeters, and you determined if that was sensitive or resistant. So this one looks sensitive, right? That one looks resistant. We've got growth all the way up to the edge of the disc, right? It's not doing anything. It's not inhibiting the growth at all, is it? So we said Staph saprophyticus was resistant to novobiasin. So if you see that, you've got Staph saprophyticus. If you see that, you've got some other kind of coag-negative staph. Here's a flow chart, an example for the workup of staph organisms. So the first thing we always want to do is the gram stain. And if it's a gram-positive cocci, the next test we do is a catalase. That helps us differentiate gram-positive cocci, right? If it's positive, we've got a staph or a micrococcus, right? If it's negative, then we've got some kind of strep species. All right, if it's positive catalase, the next test you want to do is the coagulase to test for Staphylococcus aureus. If it's negative, then you've got some other kind of coag-negative staph. And here it has you do the modified oxidase or maybe the bacitracin susceptibility. So notice the flow charts can change. It depends on your facility. This is just an example of a workup. So if it's, say this is oxidase positive and bacitracin sensitive, then you've got some kind of micrococcus species. We will just use the modified oxidase in our lab. And we'll only perform it if it's lemon yellow color. There's no reason to do it otherwise. And here it's getting you a coag-negative staph if it's resistant to bacitracin. And then they do a novobiasin susceptibility, coag-negative staph if it's susceptible. And again, you would only do this if it's from a sexually active female, right? A urine specimen from a sexually active female. Antimicrobial susceptibilities. So remember the blue book from lab last week? Did you get in the blue book? Okay. Well, it's a manual produced by this Clinical Lab Standards Institute, CLSI. And basically, they've determined what the cutoffs are for the zone of inhibition and what those ranges would correlate to. Does it correlate to susceptible or resistant or intermediate? Okay, so, and that change, they update it all the time. So for Staphylococcus aureus, we always do susceptibility testing on it. And we're not going to talk about all the different antibiotics that you can test for. Each facility will have their own battery of antibiotics that they'll test for. But I wanted to clue in on a few important ones. Penicillin, and vancomycin and methicillin. Okay. So most Staph aureus organisms are resistant to penicillin because they produce this beta-lactamase enzyme. If you remember from our lecture last week, hopefully you listened to it, beta-lactamase breaks down the beta-lactam ring in those kinds of antibiotics. So penicillin, ampicillin, they all have a basic structure that is the same, and it's this beta-lactam ring. So if the organism produces beta-lactamase, it breaks this ring, right? So it makes the antibiotic ineffective. So if you can't treat Staph aureus with penicillin because most species produce this beta-lactamase. So the infection's not going to get better. It's going to get worse. It's ineffective. So we'll use the beta-lactamase test on a couple of different organisms like Neisseria and Maricella, and we'll test for the presence of this particular enzyme. And if it's positive, if the disc turns pink or blue or whatever it is, then penicillin and all other kinds of beta-lactam antibiotics are resistant. And so you have to report that in your report, so the doctor doesn't use that type of antibiotic. Methicillin resistance, you typically use oxacillin or cefoxitin to test for this methicillin resistance in Staph aureus. So if it's resistant, it's methicillin-resistant Staph aureus. You can also use molecular methods. So if you detect this MEK-A gene using PCR, then you have MRSA as well. And there's different kinds of MRSA. You can get it from the hospital or community onset. It doesn't really matter. Basically, what I want you to recognize is if you've got methicillin-resistant Staph aureus, that's a big deal, right? So you want to make sure to pay attention to that. You would, if you do detect methicillin-resistant Staph aureus, then you report it to the infectious control nurse, and that patient has to go on contact isolation. So anyone entering that room has to wear gloves and masks and a lab coat, right? So the patients are treated differently than your run-of-the-mill patients. And then they're treated with vancomycin, which is like the highest level of antibiotic that we have to fight MRSA. Vancomycin-resistant MRSA, this was isolated in 2002, and it's a big deal because there's not much else that we can treat with other than vancomycin. So if you have an isolate that's vancomycin-resistant, a red flag needs to go off, and you want to make sure that that is, in fact, resistant to vancomycin, and it's not contaminated or something happened, because that's a big deal right there. And then the last thing I wanted to point out was this D-test. So what you're testing for is macrolide resistance. We're not going to talk about what a macrolide is or anything like that, but what you're testing for is inducible resistant to clindamycin. So usually you would think if you use 2 antibiotics, it would be better for the patient, right? You're kind of compounding the effects of the antibiotics, but that's not always the case. In this case, if you use erythromycin and clindamycin together, they're actually canceling each other out, and they're both, the organism is actually resistant to both antibiotics, and so you're going to do the patient harm. And basically all you do is you take the antibiotics and you place them closer together than you usually do. It's like 15 millimeters apart. And incubate them, and what you're looking for is this flattened zone between clindamycin and erythromycin. And that indicates that it is clindamycin, it's clindamycin-inducible resistance. So you would report both of these antibiotics as resistant. Okay, that one's kind of obvious, right? You got growth all the way up to the surface of the disc. Notice this one's got a pretty big zone of inhibition. So you don't want to mistake that. You don't want to measure that diameter and go to your CLSI book and interpret that diameter, because it's not, is it? It is not sensitive at all. Since you've got that flat line, you have to call it resistant. So make sure you know that about the for the exam. Take a look at the case in point at home. Well, we can take a look at it now. What time is it? 1 o'clock. We got time. Turn to 316. I think it's 314, unless you're using the older version. So we've got a 20-year-old healthy male, university student. He's got minor abrasions while playing lacrosse. He's got scrapes. These abrasions were ignored. Later, the student noticed small erythematous lesions resembling spider bites. So that's the redness around the lesion, right? Which he self-treated with antiseptic wipes. When a few of these lesions progressed to larger abscesses and large black central eschers, which is like, when you see black, it's like tissue death. He visited the student health clinic. And what else did we see? Let's see. The lesions were treated with incision and drainage and a topical application of antibacterial agent clindamycin. Blah, blah, blah. Let's see. He fractured his ankle during a lacrosse game, which required surgical repair of the fibula. He got screws. Before the surgery, the patient was tested for MRSA and methicillin-sensitive Staph aureus. So they're looking for MRSA or MSSA in his nasal. So they want to make sure he's already carrying MRSA, because if he goes, he needs to be treated for it if he's going under surgery. Let's see. They did a culture of the nares, and the following day we saw a catalase positive, coag positive, gram positive cocci. So if we go to our flow chart, what does that mean? What kind of organism did they isolate? If it's catalase positive, gram positive cocci, and coagulase positive, that's Staph aureus. That's a pathogen, right? Could be. They did automated antimicrobial susceptibility tests, and the isolate is resistant to penicillin, oxacillin, erythromycin, and susceptible to clindamycin. So what do we see there? If it's resistant to penicillin, what is it producing? What enzyme? Beta-lactamase. It's producing a beta-lactamase, so all your beta-lactam antibiotics are going to be ineffective. All right. What else is important here? It's resistant to oxacillin, right? What's that mean? Oxacillin is the same as methicillin, basically. What'd you say? MRSA. That means it's MRSA, right? And then we had erythromycin was resistant, but we saw it was susceptible to clindamycin. Further testing by a disc diffusion method, they did the D-zone test, or the D test, and the isolate was positive for inducible clindamycin resistance. So what does that mean? We saw a flattened zone between the, and what would we report then if it's D test positive? Would that clindamycin result still be sensitive? No. It'd be resistant if it's D test positive. So it's resistant to quite a bit, huh? So identify the isolate in the case study. We did that. Okay. The preliminary MRSA skin infections can resemble spider bites. So that's a very common thing to see. Someone will come in the ER and they have spider bites, but it's not really a spider bite probably. It's probably Staph aureus got into an abrasion or something like that. What are the risk factors associated with this organism? So in this case, what were his risk factors? He got abrasions, didn't he? So your skin protects you from getting infections usually, but if you fall, especially in the dirt and the grass, Staph aureus can be in that soil. And so those skin abrasions are destroying your protective layer, your barrier, essentially. So it's a risk factor. So he probably had got the Staph aureus, the MRSA, from that infection, and it was cleared up, but he's now a carrier. So he's at risk when he has any kind of abrasion or surgical procedure or anything like that. He's now at risk. Why is molecular testing so important? Molecular testing, you can have a result in 4 hours. Whereas if we do the disc diffusion test or the microwell test using the microscan, how long is that going to take? Got to grow the organism first. How long is that going to take? 24 hours. That's 1 day. Then once you think, oh, I've got Staph aureus, I got to do susceptibility testing. How long is that going to take? 24 hours, 18 to 24 hours. That's 2 days. Can a person die of MRSA in 2 days? Can they die in 8 hours? Can they die in a matter of hours if they're septic? Oh, yeah. So if you can cut that time down to 4 hours, it can really save lives. So that's the importance of molecular methods, sensitive and rapid. So as far as the susceptibility testing, make sure you know about methicillin resistance, your beta-lactamase test for penicillin, and other kinds of beta-lactam drugs, your inducible resistance, and the vancomycin. All right, strep. You want to take a break? Strep's a lot longer than staph. There's a lot more. Okay, Streptococcus. What test do we do to differentiate gram-positive cocci? Or if we don't know if it's a staph or a strep, what test are we going to use to figure it out? Catalase test. Very good. And what's a positive catalase test look like? Bubbles, right. All right, so we talked about this side of the flow chart. And usually if you think of flow charts, you want to put positive reactions to the left and negative reactions to the right. And that way, I like to memorize flow charts. I write it over and over again. And that way, if you visualize your flow chart and you can see your organism identity all the way on the bottom right-hand side of your page, then you know, well, all those tests are negative. Or if it's in the bottom left-hand of your page, then you know, well, all those tests were positive. So it might help you on the test if you can visualize that. So Streptococcus, Enterococcus, and other gram-negative, gram-positive cocci. These are your objectives. They're kind of the same that we talked about for the last chapter, the different characteristics and infections and how to identify it. So your general characteristics for your Streptococcus and your Enterococcus. They used to group Enterococcus with strep, but recent advancements have kind of pushed Enterococcus out on it's in the same kind of category, but it's not a Streptococcus. But they're gram-positive cocci in pairs or chains. Notice it's bolded, so it's important. So if you see chains, you want to think of a strep or an Enterococcus. They're catalase negative, but keep in mind you can have false positive reactions, like if you're taking growth from media and you pick up some of that sheep blood agar by accident, that sheep blood agar can cause the catalase to bubble. So you want to make sure that you're careful when you're picking up your colonies to have good technique and you're just picking up the colony. Enterococcus, he can be kind of tricky because he's very weakly positive, but you'll see it in lab today. Enterococcus is very, very gentle, slow production of bubbles. And what are we looking for on the catalase? A vigorous production. So we want to see like a violent production of bubbles. If it's not violent, then it's negative. These guys grow good on sheep blood agar, chocolate agar, on your selective agars. We talked about selective strep agar, or SSA, which selects for strep, and so staph won't grow on it. PEA, and this should be CNA, but my autocorrect keeps changing it to CAN, and I didn't catch that one. They'll only grow gram-positive cocci, so they'll grow staph and strep. So here it is on gram stain. They're kind of crummy pictures, but we can see it in nice long chains. Enterococcus will do this a lot of times. And they can see they kind of look like clusters almost, but they're like chains next to each other or pairs. So it can be kind of tricky when they're not doing the obvious chaining. The first thing you want to do to identify a streptococcus. That's a good test question. You want to clue in on the words of test questions. Did I say what test is used to differentiate gram-positive cocci? Or did I say what test is used to differentiate streptococcus? Or what is used to differentiate streptococcus? So if you're going to differentiate gram-positive cocci, you want to use the catalase. But if you want to differentiate streptococcus species, then you've already done your catalase, right? That's how we know it's a strep. So the hemolysis pattern is the most helpful way to differentiate between the streps. It sort of leads you down your path of identification. Okay, it depends on what hemolysis pattern it is. Okay, so remember your beta hemolysis, excuse me, is a complete hemolysis of red cells. So it's your white hemolysis. So here's an example of your beta hemolysis. And then your alpha hemolysis is when it's kind of green around the colony. That kind of looks sick. The red cells aren't cleared away completely. They're just kind of sick and dying. And then your gamma is non-hemolytic. So these are the different strep species that we're going to talk about. We've got your strep pyogenes, which is your group A strep, your strep A galactica, which is your group B strep. We've got strep bovis, which is your group D strep. We've got your Enterococcus, which has also has the D antigen on it. So it's kind of in the same group, but it's not. It's kind of divided from itself. So, and then we have this is the Virulence Streptococcus. So it's like a whole group of your leftover streps. All right, and then we've got your strep pneumo, which doesn't have an antigen, that it's Lancefield group antigen. And then your virulent strep can be any group. So this is a nice chart. It tells you the hemolysis pattern, the typical hemolysis pattern. So your pyogenes and your A galactica are usually beta hemolytic. Your strep bovis is usually alpha hemolytic or non-hemolytic. Enterococcus can be any kind of hemolysis. Your strep pneumo is alpha hemolytic. And then your virulent strep, or all your leftovers, can be anything. These are the disease associations. You've got rheumatic fever, scarlet fever, pharyngitis, which is your strep throat, right? Acute glomerular nephritis, and other kinds of pyogenic infections. So that's your group A. Group B strep can cause neonatal sepsis. Remember we talked about limb broth and screening pregnant women for group B strep. Okay, it's very important that we find out if pregnant women have this group B strep in their genital areas, because it will cross into the fetus and the newborn. It has a capsule, so it can cross the blood-brain barrier and cause meningitis. It can cause pyogenic infections, which is like we talked about scalded skin syndrome with the Staph aureus. It's the same thing where the skin is sloughing off, but it's not the upper layer of the skin. It's like the whole skin, and most likely it will kill the fetus or the newborn if it's an acute infection. So it's very important that we find out in pregnant women if they have it or not. Group C strep, we're not talking about. Strep bovis, you want to think of endocarditis. Enterococcus usually causes your urinary tract infections. Your strep pneumo is your pneumonia. It also produces a capsule, right? So it can cross the blood-brain barrier pretty easily and cause meningitis. And then your Virulence Streptococcus is usually normal flora, but it can cause dental caries and endocarditis too. So we'll associate specific types of infections with certain organisms, and I've highlighted them in this subsequent slides. So this is the Landsfield classification, and it's kind of outdated nowadays, but they might still use this in the hospital. And basically, it's an antibody against an antigen on the surface of the organism. So if you've got a plate growing and you know that it's a strep genus, but you don't know which one, you take a drop of each of these antibodies and say you'll put your A there, and your B there, and your C here, and your D there, and your F, and your G there. And then you touch a colony of your unknown and spread it in each one of these circles. And if it agglutinates, it indicates the antigen is present, right? So if only A agglutinates, that means you have Landsfield group A on the surface, right? So that means it's strep pyogenes. If only B agglutinates, then you'll have group strep agalactica. Okay, so it's helpful. Group D is found on both strep bovis and enterococcus, so you're not done there if you've got D antigen. You've got some more identifying to do, but it's helpful, and that's where this group A and group B comes from that I'm referring to. Okay, so strep pyogenes, or group A strep. Some of the virulence factors, the M protein, which helps to evade phagocytosis. And when we do the rapid strep test, which I meant to do today and I forgot about it. Hopefully we'll do it in lab. If not, we'll do it another day. It's simple. It's just taking a throat culture, a swab from a throat culture, and you immerse it in this liquid. You basically do 3 drops of reagent A and 3 drops of reagent B, and it's this enzyme that extracts an antigen from the surface of the bacteria. And it extracts this M protein off of the surface, so it's available to react in our test, right? So then we take a couple of drops from that reaction mixture and put it in our cassette and let it sit for 4 or 5 minutes. And if we see a line, it means it's positive for group A strep or strep throat. And if it's negative, then it's negative for strep throat. So that's where that M protein comes from. And it has to be extracted from the surface of the antigen before you do your test. Capsules are present. They do evade phagocytosis. It also streptolysins, which are enzymes that can hemolyze red cells. So we'll see it on our blood agar plate. We'll see the beta hemolysis. And that's produced by 2 different streptolysins. Okay? There's streptolysin O, which is oxygen labile, and streptolysin S, which is oxygen, I say stabile because it helps me remember that S is stable in oxygen. So what will happen is if you think someone's got strep throat, you take a throat culture, right? And you swab that swab on a blood agar plate. Okay? And you isolate, you do your 4-quadrant streak, and you incubate it for 18-24 hours. You're going to put 1 in oxygen, and you're going to put 1 in an anaerobic environment. Okay? And when you pull it out, you're going to look for beta hemolysis, right? If the organism produces streptolysin O, that enzyme is oxygen labile, so it's only active in anaerobic conditions. So we will only see beta hemolysis on the anaerobic plate. All right. If it produces only streptolysin S, that's oxygen stable. So we'll only see beta hemolysis in the oxygen incubated plate. Right. If it produces both, then we'll see it in both plates. Right. So it's important that somehow you also test for streptolysin O, because it may just produce the oxygen labile So you can either incubate 2 plates, one aerobically, one anaerobically, or you can stab the auger in the first quadrant. They might have you do that. When you stab that auger, you're creating an anaerobic environment in the auger, right? Theoretically. So then you would look for any beta hemolysis in the first quadrant. So anyways, that's that. There is a streptolysin test, but it's not on the board registry, so we're not going to talk about it. Let's see, some other virulence factors, DNases, the hyaluronidase, which breaks down some connective tissue, helps it spread. Streptococcus pyogenic exotoxins, which are toxins that produce that red rash that you might see, like it's scarlet fever. Okay, so number one infection that strep pyogenes causes is your strep throat or your pharyngitis. Okay, so you see that word in a test question, you want to think of this organism. Now, if strep throat isn't treated, if it goes untreated or if it's not cured, then there's what's called post-streptococcal sequela can develop. And they're like secondary infections caused by this organism. And they're very serious infections. So rheumatic fever is one, and it's where inflammation happens in the joints and in the heart and the blood vessels and subcutaneous tissues, and it can cause some very serious damage to heart valves. And that doesn't go away. Once they cure the infection and cure the rheumatic fever, that the damaged heart valves don't go away. They're a health condition for the rest of their life. Same thing's true with acute glomerular, can never say this word, acute glomerular nephritis. So you see nephritis, you want to think of kidneys, the nephrons of the kidneys. So it's an infectious process that causes these antibody immune complexes to deposit in your kidneys, and it causes damage and inflammation. Again, once they cure the infection, you still have kidney problems, kidney damage. You can have fluid buildup. We had a girl I went to school with had acute glomerular nephritis, and she had a lot of fluid buildup in one of her legs all the time. I'm not sure why that happens. I don't know if it has something to do with the kidneys, but one leg was always larger than the other leg, and it was painful for her. So I think of her every time. Some other infections, scarlet fever, which comes with a rash on the trunk and the limbs. You can have skin infections like impetigo and cellulitis. You can have sepsis if it gets into the bloodstream. Necrotizing fasciitis is your flesh-eating disease. And there's a woman who was in the news a couple years ago, a young woman in her 20s, and she was doing the zip line in Hawaii, and the zip line broke, and she landed in like this little creek. And it wasn't a far fall. She had a couple abrasions on her legs. And this group A strep, the flesh-eating disease, set in her leg. And she started getting infected. So they started treating her for MRSA, but it wasn't MRSA. It was strep. And she ended up losing like her whole left leg, I think, part of her right leg, maybe some of her fingers. So they had to amputate it because the tissue death is irreversible. Lab diagnosis for group A strep. Typically just a throat culture if it's pharyngitis. Just rub the swab in the posterior pharynx of each tonsillar back there in the throat. We don't ever collect them. But a good sample of both tonsils. If there's any kind of exudate, usually if they've got strep throat, they've got like white spots in the back of their throat. So you want to target those white spots. And then you don't want to touch the tongue and the uvula. Once you've collected the sample, of course, you want to put it on sheep blood auger. You might use some kind of selective auger like SSA plates that select for strep, right? Because there's going to be a lot of normal flora in that throat in addition to this group A strep. Let's see. Do the quadrant streak to detect group A strep that only produces the streptolysin O, which is hemolysis in the anaerobic conditions. You want to streak a plate and either incubate it anaerobically or stab the first quadrant of the other plate. You can use selective auger to help you spot that beta hemolytic strep, and then incubate your plates. And basically you just pull them out of the incubator and all you're looking for is any kind of beta hemolysis. Okay, you don't care about anything else that's present usually. So it makes it a little easier. So here's the colony morphology for group A strep. They're usually a lot smaller than staph. Remember how big staph was? These are a lot smaller than staph, and here's a wide zone of beta hemolysis. So notice it's a huge zone compared to the size of the colony. You've got a huge zone of beta hemolysis. Here again, we've got this is a throat culture. They stabbed the auger 3 times, and we've got tons of normal flora, right? But all we're interested in is what's beta hemolytic. Biochemical tests, it says catalase positive. That needs to say catalase negative. That's a big mistake there. Make sure you correct that. All streps are catalase negative, right? It's bacitracin sensitive, and it's PYR positive. Notice those are bold, right? Here are some more tests that are helpful to differentiate each of the different types of strep. So you might want to refer to this later. Now, we don't talk about all these tests, so if we don't talk about them, don't worry about them. But the key test for group A strep is the bacitracin and the PYR, and maybe in the Lancefield typing. So it's A. You'll detect A with your Lancefield typing. For other specimens, these are some important tests for other types of strep, and we'll talk about them shortly. Okay, group B strep. When you think of group B strep, you want to think of this invasive disease of newborns. It can either be an early infection or a late infection, and usually the late infection is the milder disease. They can recover from that. Usually, we'll see meningitis. So think of newborns and meningitis with group B strep. Let's see. Most of the time, it occurs through vaginal transmission during birth from the mother. You can also see if the membranes rupture, it can spread to the fetus. They develop pneumonia or meningitis with bacteremia, so it gets in their bloodstream, and usually a very high mortality rate. Adult infections, you might see endometriitis or wound infections or endocarditis. But I want you to know about newborns and meningitis for this organism. That's the primary infection. And I always remember this story that someone had told me about a newborn that had died from the infection. And the parents wanted to get the newborn's footprints before it was buried. And they tried to talk him out of it, but they were very persistent. And so they painted the bottom of the foot. And remember, it's a skin disease, so it's like sloughs off skin. And so they painted the bottom of the foot with the ink, and then they touched it to the paper. And the skin came off when they lifted the foot off. I mean, it is a bad infection. So I can't stress to you the importance of microbiologists in that fashion. Identifying the organism in these samples is really life or death. So it can't be taken with a grain of salt. They're very important. Okay. Oh, this I wanted to point out on this picture here. This is group B strep. Remember, group A strep had a very wide zone of beta hemolysis. This is beta hemolytic too, but it's a very narrow zone compared to the size of the colony. You almost have to pick the colony up and see what it's doing underneath to the red cells. So if you see narrow zone of beta hemolysis, you want to think of group B strep. When you see wide zone of beta hemolysis, you want to think group A strep. So here's our flow chart for group B strep. We got catalase negative, gram positive cocci. We might do a bacitracin disc, which is helpful. You might do it for all beta hemolytic streps because it's helpful to identify group A strep. But in this case, it's resistant for group B strep. Next test you want to do is the CAMP test, and that identifies your organism. If it's CAMP positive, then it's group B strep. Another test you could do instead of the CAMP would be this hippurate hydrolysis test. So if it's purple, I don't even remember I guess you check to see if the organism's able to hydrolyze hippurate, but I just remember that a purple reaction is positive. If it's CAMP negative or hippurate negative, then it's some other kind of streptococcus. Okay? Let's see. So detection of group B strep, primarily we collect the vaginal or rectal material between 35 to 37 weeks gestation, and you can inoculate that swab into some kind of a selective broth, right? And that selective broth is going to target the growth of group B strep and inhibit the growth of other kinds of flora, and that way you can optimize the recovery of this organism. So there's different kinds by different manufacturers. We talked about the limb broth in our lab. There's also the trans vag broth, and the strep B carrot broth is really cool because it'll turn orange if group B strep is present. So you inoculate this broth and incubate it for 18 hours, and the next day you take that broth and you inoculate a sheep blood agar plate and incubate that at 37 degrees for 24 hours. And then you look for any kind of beta hemolysis. You look for that typical colony morphology of a narrow zone of beta hemolysis and identify it if it's there. So you can also use nucleic acid tests. Those are available also. So all positive women need to be treated with antibiotics in order to reduce the risk to the infant. Strep pneumo. So virulence factors for strep pneumo, many strains have this capsule, which can make it more difficult to treat. We can also use certain kinds of antisera to help us identify strep pneumo if it has this capsular, because it has these additional antigens. We can also develop, like I was part of it, developed a vaccine against these capsular antigens. So many times it's given to the elderly, so they don't come down with this kind of pneumonia. It produces toxins like hemolysins, this immunoglobulin A protease, which is a protein that breaks down immunoglobulin A in your saliva and in your tears. Uramidase, hyaluronidase. The clinical infections for strep pneumo, pretty simple. You see the name, what do you think it causes primarily? Pneumonia, right? So commonly see it in the upper respiratory tract. Respiratory tract is divided into two sections. The upper respiratory tract is basically anything above your bronchioles. So it's very common in the upper respiratory tract. And we see it a lot in elderly patients and people with other kinds of diseases that might be incapacitated for a while and not moving around. It can occur as a secondary infection, so maybe they're taken down by a virus. Then strep pneumo can set in if you aspirate an organism. It can cause sinusitis, which is just your sinus infection, otitis media, which is more of your behind the eyes, bacteremia when it gets in the bloodstream, and it's got a capsule, so it can cause meningitis. The capsule allows it to cross the blood-brain barrier easily. Lab diagnosis of strep pneumo, it's a gram-positive diplococci with, it's a lancet shape. So it's kind of pointed on the outer ends and rounded on the center. And it looks like an ant with no legs. You can use a capsule stain to look for a capsule, but you can also see the capsule in the gram stain, right? What's it look like on the gram stain? Like a clearing around the organism that doesn't stain. When you culture it, it's a capnophile. What's that mean? Needs more CO2. Excellent. It grows on sheep blood agar, chocolate agar, and selective agars like CNA and PEA and your SXT and SSA. It's transparent. It doesn't have any kind of color. It can be very mucoid, especially if the organism produces a capsule. Umbinate, which means it's got a dip in the center, so it kind of looks like a donut. And alpha hemolytic. So make sure you know that colony morphology. It should be bolded because it's so important. It's catalase negative, opticin disc susceptible, so we'll see a zone of inhibition, and then it's bile soluble. Here it is, the colony morphology in the gram stain. So we can see a nice capsule, see the zone of clearing around these organisms where it doesn't stain. And then we've got nice umbinate colonies with a dip in the center. Almost looks like a drop of water or something. Very mucoid, alpha hemolytic. Can't really see the color. There's no color to the colony, but we see the alpha hemolysis underneath it, right? Everybody see that? Good. Antimicrobial resistance. Like I said, we have the vaccine available, so that helps reduce the infection severity in patients that are more highly at risk. Virulence Streptococcus, this is normal flora in the upper respiratory tract. It's alpha hemolytic, so many times when we get a sputum culture and we're looking for strep pneumo, we're differentiating it from this organism that is normal flora. It's very normal in the genital tract and the GI tract. Some might require CO2 to grow. These are the different organisms that are in that group, but I don't want you to memorize those. We're just calling them Virulence Streptococcus. They're like the leftovers. Here, what I want you to recognize is that the organism is generally opportunistic. It's normal flora, but it will cause disease if it's given an opportunity. And generally what we see is this SBE, or subacute bacterial endocarditis. So it's inflammation of the heart. And then other diseases, tooth decay. You might have a case study where someone has really bad dental work or dental poor teeth. So it can cause infections in that way. And it can cause other kinds of infections, but I want you to link those two particular infections with this organism. So when you see SBE, you think of Virulence Streptococcus. Now this group D and Enterococcus, group D can cause endocarditis also, but it's not subacute endocarditis. I don't know what subacute is, honestly. I've never Googled it, but just always recognize SBE with Virulence and endocarditis with group D. It can also cause urinary tract infections, wound infections, abscesses. So typically we need to distinguish group D Streptococcus from Enterococcus, which also has the group D antigen on it. So both of them can be alpha, beta, or non-hemolytic. They can be all three if they want to. It doesn't matter. And Enterococcus is bile esculin positive, sodium chloride positive, and PYR positive. Group D Streptococcus is also bile esculin positive, but it's sodium chloride negative and PYR negative. So that's how we would differentiate between the two. Okay? So sodium chloride is just a 6.5% suspension of sodium chloride, and if the organism is able to grow, we'll incubate it for 18 hours and look for turbidity. That's it. So if it grows, we've got Enterococcus. If it doesn't grow, we've got group D strep. All right? And then the PYR test is also confirmatory. You might use it instead of sodium chloride, or you might use it instead of bile esculin. So it just kind of depends. You can use any variety of those tests. So here's just an example. If you've got a catalase negative gram-positive cocci, it can have any kind of hemolysis pattern. You do a bile esculin test and it's positive. That means you either have group D or you have Enterococcus. I got to differentiate between those two. What could I do? You can either do the sodium chloride test or you can do the PYR test. So Enterococcus is going to be positive for those. Group D is negative. Notice group D is negative for all these tests, so it's on the right. Enterococcus is positive, so it's on the left. So if I forget which one's PYR positive or which one's sodium chloride positive. If I can remember where they are on my flow chart, I can remember what those reactions are. So Enterococcus, it has this very weak bubbling with the catalase, so you want to make sure that you interpret that as negative and not positive. It's not vigorous, so it's negative. It can grow in harsh conditions like bile and salt and alkaline pHs. The colony morphology is small, gray. It can be alpha, beta, gamma hemolytic. There's another mistake. I wonder where that's coming from. I downloaded this off the website. And, so it's catalase negative. Make sure you correct that. All your streps are catalase negative. It's bioesculin, sodium chloride, PYR positive. Now you might do the Opticon disc or the bacitracin disc to help you rule out if it's beta hemolytic. You might do the bacitracin disc to help you look for group A strep. Or you might do the Opticon disc if it's alpha hemolytic to help you identify strep pneumo. So in that case, it's always resistant. Novobiocin, it's sensitive. Let's see. Clinical infections for Enterococcus, the urinary tract infection is the most common, so that's what I want you to know. But it can also, it can also do other things for you. We're not going to speciate Enterococcus too much. These are the main species that you'll hear about is Enterococcus faecalis and faecium. So these are the different tests you might use to see if it uses arabinose. If it does use arabinose, then you have faecium. If it doesn't, then you have faecalis. I wouldn't worry about telling the difference between the two. Okay, Enterococcus and antimicrobial resistance. The main thing with Enterococcus to test for, you'll have a whole variety of different antibiotics that you'll use, but what I want you to clue in on is the vancomycin resistance. If it's vancomycin resistance, Enterococcus, then the patient's treated differently, just like the patient would for MRSA. They're under contact precautions because they don't want to spread this VRE to other patients in the hospital. Okay, so here's an example of a flow chart. So we do our gram stain first. We got gram-positive cocci. We do our catalase to determine if it's staph or strep, right? If it's strep, we're going to take a look at our colony morphology and what kind of hemolysis do we have. So that tells us which pathway we're going to take based on that hemolysis. That's the most important thing to differentiate between Streptococcus is the hemolysis pattern. So if it's beta hemolytic, I want to look for group A strep. That's the first pathogen on the list, right? So I might do a PYR test or a bacitracin disc to determine if I have group A strep. If it's PYR positive, then most likely I have group A strep. If it's sensitive to bacitracin, that's a presumptive test also for strep pyogenes. Okay? If it's negative for those tests, I want to look for group B strep because that's also beta hemolytic, right? So I would do the hippurate hydrolysis test or maybe the CAMP test. Group B strep is positive for both of those. Whereas other kinds of strep are going to be negative. If it's negative, then I've got maybe an Enterococcus or a group D. So I would do the bioesculin. So Enterococcus in group D is positive for esculin, whereas other kinds of beta hemolytic strep are negative. If it's positive, then I want to do the PYR or sodium chloride test to differentiate between Enterococcus and group D. Okay, so that's just kind of an example of how to work it up. For alpha hemolysis, colonies that are alpha hemolytic, I might do the Opticon disc because strep pneumo is sensitive to the Opticon disc. I might also do the bile solubility test because strep pneumo is bile soluble. If it's not, then I would I either have Enterococcus or group D or something else. So I would start with those same tests to differentiate between those organisms there. And then if it's non-hemolytic, then I've got one of these streps. So I would start with my bile esculin, sodium chloride, PYR. Okay? Okay, so these are the different tests. This is the bacitracin susceptibility. It's just an antibiotic, and we're looking to see if the organism is sensitive or resistant to the antibiotic. And it's used to presumptively identify group A strep. Okay, group A strep or strep pyogenes is sensitive to the A disc or the bacitracin disc. Okay, so notice here we've got a nice lawn of growth of organism, and we can see it's beta hemolytic because it's killing all the red cells in this area, except where it's not growing. We've got a zone of inhibition around the A disc. Any size of inhibition is positive, considered positive. On the right side, we've got an organism. It's not beta hemolytic, and it's growing all the way up to the surface of the disc. So it's resistant. If you've got a sensitive reaction, then you confirm it with the PYR test. So this is a presumptive test. The bacitracin is a presumptive test. You can't say with 100% confidence that it's group A strep until you do a PYR. And if it's positive, then you have group A strep. Okay? A disc, bacitracin disc, group A strep. All right, the CAMP test, this is used to identify group B streptococcus. And basically, if the organism produces this CAMP factor, then wherever it interacts with a beta lysine from Staph aureus, you're going to see enhanced hemolysis. So what we do is we take this beta lysine producing Staph aureus and we make a line in our sheep blood agar. Then we take a little bit of our unknown organism that we think might be group B strep, and we streak it perpendicular to that line. You don't want to touch, you just want to get very close to it. And then you incubate it for 24 hours and you pull it out and you want to see this arrowhead shape of enhanced hemolysis. And so where these two types of beta hemolysins are coming together, we see an enhanced zone. So you can call that group B strep. The hippurate hydrolysis test, basically I just want you to know that group B strep is positive and that a purple color is positive. It's helpful to differentiate beta hemolytic streps. Your PYR, I don't memorize this substrate that's getting hydrolyzed. I just kind of recognize the PYR and the naphthalamide. If the organism is group A strep or Enterococcus, it breaks down this substrate. It has something in it that breaks down this substrate, and we'll see a pink color produced. So this is a positive PYR. We just smear some of the colony on the disc, wait 2 minutes, and apply the PYR reagent or the substrate, and it'll break it down if it is either of these two organisms. So this is a more specific test than the bacitracin or the A disc. So like we talked about the Opticin disc being a presumptive test, or we talked about the bacitracin disc being a presumptive test, you have to confirm it with the PYR test. So you've always got to follow it up with the confirmatory test. This is the bile esculin test, and there's a variety of different ways to perform this test. You might inoculate the organism on this BE plate. You might inoculate a tube. You might inoculate a little biochemical test tube with it. But all you're basically looking for is a black precipitate. So if the organism is able to grow in its bile and hydrolyze the esculin, we'll see the black precipitate. So that means you either have group D strep or you've got Enterococcus, because both of those are positive for bile esculin. The salt tolerance test is useful to differentiate Enterococcus from group D. And all you do is inoculate this broth with the organism, the test organism, and incubate it, and you're looking for turbidity. If it's hazy, it's Enterococcus. If it's not hazy, it's group D. The Opticon susceptibility test, this is useful for differentiating alpha hemolytic colonies. So basically what you're looking for is strep pneumo in this case. So strep pneumo is sensitive, whereas Virulence Streptococcus will grow all the way up to the surface of the disc. Okay, so here we've got a 14 millimeter mark for a 6 millimeter disc. That's talking about the diameter of the disc. So if it's 6 millimeters, this zone of inhibition, the diameter needs to be at least 14 millimeters or more to be called sensitive. You can also, you want to back the P disc up with a bile solubility test. It's like your confirmatory test for strep pneumo. The bile solubility reagent causes strep pneumo to go into this autocatalysis. Or basically, it's going into suicide mode. And so there's two ways to do it. You can take a drop of this reagent, the sodium deoxycholate, and put it on a colony, and then incubate it for 20 minutes. And if the colony disappears from the surface of the plate, then it underwent suicide, basically. It's gone. So it's positive. You can also put it in a solution of this reagent, the sodium deoxycholate, and if it clears, then you have strep pneumo. All of the organism was destroyed in the solution. If it's not strep pneumo, it'll remain hazy. So this is the diagnostic test. The one thing you want to remember is that the colony might float away in the reagent, so make sure that when you're looking and interpreting it off of the culture plate, you're looking for to see if the colonies may have just moved or did they completely dissolve. And then if you want to take a look at the case in point, can you identify the most likely causative agent? Let's look at that case in point and see if we can figure it out. Try to clue in on some important characteristics. So we've got a 9-year-old boy, and he's got a fever and a sore throat. What's that tell me right off the bat? Pharyngitis, right? What do we think of when pharyngitis? What disease? Strep throat. So what organism causes strep throat? Pyogenes, right? Group A strep. Very good. Okay, so that's what we're thinking in our head. Tonsils were swollen. They swabbed the tonsils and inoculated onto sheep blood agar. After 24 hours of incubation, small, tiny, translucent colonies showed beta hemolysis. So is it likely that, what's the most likely identification? Strep pyogenes, because it's beta hemolytic, right? And it kind of coincides with the case of the patient and what they're suffering from. What reactions is strep pyogenes? What test would we do first? If we need to identify that beta hemolytic colony, what test would we do first? Well, first, what would we do at the very top of our list? We have an idea of what it is, but we have to confirm it. So what's the very first test we do when we're going to identify an organism? Gram stain first. We've got to make sure it's a gram-positive cocci, right? All right, so we do our gram stain first. We see gram-positive cocci. Then what test are we going to do? Catalase, right? Could be a staph, could be a strep. I don't know. Got to do a catalase to make sure. So what would strep pyogenes be? Negative. Catalase, negative. All right, so strep pyogenes, it's a beta hemolytic colony, right? So we're going to use the beta hemolytic pathway. Did everybody print off the PowerPoint slides for lab? Okay. Then look at your book. I think there's a flow chart in there for beta hemolytic. What test do I have to do? To identify this organism. Page 343. So colony morphology, find beta hemolysis. What tests could we do? PYR, or we could do a bacitracin test. All right. So let's see. The bacitracin disc is sensitive for group A strep, and the PYR is positive. So the bacitracin disc, remember, it's a presumptive test, so you have to follow it up with the PYR. All right. So you should see positive and susceptible. What if it's enterococcus? What if it's a beta hemolytic enterococcus? It's going to be PYR positive, isn't it? So I don't quite like this particular flow chart because it's having you do a PYR and then you go to the right because it's negative in order to get to enterococcus down at the bottom. See that? And then you do a PYR right above that and it's positive. So it's it's a crummy flow chart, in my opinion. Anyways, so if it's alpha hemolytic, you would do an opticon disc or maybe a bile solubility test because you want to rule out strep pneumo, which is the primary pathogen. That's alpha hemolytic. All right? So just keep in mind there's a lot of different ways to identify organisms, and each of your facilities that you might find yourself working in is going to develop their own algorithm based on the tests that they have available. So it might change. But we will learn so that we can identify organisms in there, and we'll also learn a couple extra tests that we won't be able to actually perform in our lab, but for the BOC, for purposes of the BOC, we'll have to learn them. Any questions? All right. Make sure you get those things turned in to me next week before the exam. If you have any questions, make sure you jot them down so you can ask me before the test. You can